To have Michael Darden as a presenter. Michael Darden is an associate professor at the Carey Business School of Johns Hopkins University, where he teaches courses in healthcare markets and related health economic topics. He's also a research faculty fellow at the National Bureau of Economic Research and serves as a co-editor of the Journal of Human Resources. His research focuses on health economics and health econometrics, with many articles published in peer-reviewed journals, including the Journal of Political Economy and the International Economic Review. We are very honored that Michael is going to participate to our seminar series. Today, he's going to present a paper on endogenous screening and health behaviors. So for those who want to ask questions, feel free to write in the chat, and Hans van Kipperloes will take care of the chat and the questions. Michael, thanks again, and the floor is yours.
Great, thanks so much. Let me do my slides here.
Fantastic.
Yeah, this is great. Thanks so much for the opportunity. Let me just do full screen here. This is joint work with Alex Hoagland, who's on the call right now, and I think he has about 15 more minutes on the call, so get the hard questions out early before he leaves. This is a really new paper, and so you can tell actually that the title has changed a little bit. We're really excited to present it for the first time and get some feedback from the audience. So broadly, I want to motivate with just
Michael,
thinking about.
Michael,
Yes.
just to stop you, like now, currently we don't see the slides.
Oh, sorry.
No worries.
Okay, let's try it. Does that work?
Yes, but not in full screen mode yet.
Okay, sorry.
No worries. And now it drops off again.
Oh, all right. Well, I could do not full screen mode.
Yeah, that's fine. If you zoom in a little, I think that should work too.
Oh, okay. How's that?
Yeah, that works.
Ooh, not that much. Okay, let's make it bigger. There. Okay. Great. So preventive care is, from an economist's perspective, I think is really interesting because it presents this intertemporal trade-off that's associated with like a foundational form of human capital, right? And like, so if you go back to, Kenneth Arrow's work, he wrote a lot about how there are a lot of these uninsurable risks that exist in health. And preventive care offers this kind of pseudo insurance in a sense, because you can, as it sounds, you can relatively cheaply pay to invest in your health and potentially prevent major chronic disease. It's thought to be underutilized, and that underutilization is mainly coming from a kind of a medical definition. I hope at the end of this project that Alex and I will be able to say something about, in a welfare sense as well, in the context that we're studying. But preventive care clearly carries enormous policy implications too. If you follow the work of Amy Finkelstein over her career, at the beginning of her career, she's talking a lot about ex ante moral hazard and the kind of inefficiency of ex ante moral hazard. And if you read her most recent book, it advocates for kind of universal basic coverage in the United States, which isn't surprising for a European audience, but is quite something here in the U.S. So huge policy implications, and this is a very small subset of the literature here in economics and in medicine. So this paper, we're going to focus on lung cancer. And just to level set a little bit, lung cancer is the third most common cancer in the US, and it's the number one cause of death from any cancer. So of the cancers, more people in the US die from lung cancer than any other type. I think really importantly for our discussion in our paper today is that 80% of cancers are caused by cigarette smoking. If you just pause there for a minute and think about other kinds of cancer, like breast cancer, for example, and mammography screening, there's a lot of literature in the economics, in health economics on those topics. But medically, there's not one single cause of breast cancer. There's a variety of associations, associated factors that would predict breast cancer. But in the context of lung cancer, the inhalation of smoke from combustible tobacco is broadly and widely believed to be the number one cause of most of the lung cancers that we observe. And so in that sense, you can almost think about smoking and the actually not smoking, choosing to quit or not initiate smoking as a form of prevention, um, which I think is an interesting take on a risky behavior that I know that everybody in this room has thought about some. The other form of prevention that we really want to think about is screening. Okay, so low dose computed tomography lung cancer screening has been around for a long time. As it sounds, so low dose or providing a lower dose of radiation, making these screenings safe on an annual basis, with the goal of detecting lung cancer early. And why is it important that we detect it early? You can see very clearly from data in the US that the 5-year survival is greatly impacted by when the cancer is diagnosed. So overall, the picture is not very good here. So 28.6% of people who are diagnosed with lung cancer are alive 5 years later. But there's a clear gradient on when the diagnosis happens in survival. So if the cancer is diagnosed at kind of an early stage, like a stage one or two, in a localized way, so the cancer has not spread from the lungs, 60% of people are alive at 5 years. And that falls dramatically down to 9.4% for those who are diagnosed with cancer that has spread beyond the lungs to organs elsewhere in the body. So clear reason for wanting to screen because screening can catch cancer early. Clear reason for not smoking because, again, smoking is going to be causing most of the lung cancers. So I want to give you a little bit of background because it's relevant for our discussion on policy on lung cancer screening in the US. So in 1996, the United States Preventive Services Task Force gave CT lung cancer screening a grade of a D. It cited poor evidence on mortality, concern over false positives. So, falsely diagnosed with lung cancer, and that leads to invasive testing that is itself kind of dangerous. And there was a lack of randomized control trials. So there's not good evidence, in the 90s on how effective cancer screening could be. That motivated the National Lung Cancer Screening Trial. So this happened from 2002 to 2010, where the National Cancer Institute in the United States randomized 53,000 people to receive either low-dose CT scanning or radiography 3 times. And they focused on a very high-risk population. So a group of people who were 55 to 74 who had 30 pack years of smoking history, where a pack year is simply smoking 1 pack a day for an entire year, and who were recent or current smokers. And so this was, a major initiative. And the main result was that they had more lung cancer diagnoses in the CT arm than the radiography arm. And there were fewer deaths in the CT arm than in the radiography arm. That was the takeaway message. And if you then think about the milestones that come from that, so in 2011, they published the results of this study in the New England Journal of Medicine with the headline results: screening with the use of low-dose CT reduces mortality from lung cancer. This followed by, in 2013, the USPSTF recommended for the first time CT scanning in adults age 55 to 80 with a 30-pack year history who currently or recently smoke. And they gave a recommendation of a B. And a B is important because if the task force recommends something with an A or a B, it's eligible now for coverage under Medicare and Medicaid. And so following this recommendation in 2015, CMS, the Center for Medicare and Medicaid Services, said, okay, Medicare and Medicaid will cover screening now for this population. Then in 2021, they actually broadened the recommendation. So they said now it's recommended for adults age 50 to 80 with a 20-year pack history, not 30, who currently or recently smoke. And following that, there was a national coverage update where Medicare would pay for screening for that group as well. And so this is important because in addition to Medicare and Medicaid, private insurance typically follows these guidelines as well. So you can think about this decade is essentially going from a place where screening was out of pocket, you had to pay for it, to if you were eligible, basically all insurance would cover it for free. And Alex and I have done some work on this. Last year, we published a paper in JAMA Network Open where we said, what happens at age 50 when turns age 50? And you can see the blue line is people with less than 20 years of pack history. So they're not eligible for free screening. And the red line are people with 20 plus pack years who are current and recent smokers. And you can see a real divergence in screening propensity around age 50. So a couple of headlines that came out of this paper. One is that of eligible individuals in the US, only about 16% choose to screen. And again, that screening would be free. So that kind of speaks to this underutilization question. And then of the people who screen, only about half of them were eligible, which I think is really interesting from an economist perspective, because it says, for half of the people who are screening, they're paying out of pocket. They're choosing to do this and they're paying some out of pocket. The typical price is about $300. So, not prohibitively expensive, but not cheap either. And so, we always think of, people not valuing care at the total cost in the US. But here's an example where half of people who are engaging in the activity actually are paying out of pocket. And so this led us to kind of think, oh, we should probably do more here in a more formal economic way. So in this paper, what we're going to do is write down a model of screening and smoking decisions where we kind of consider these decisions jointly. We think that they're simultaneously determined. We're going to test competing mechanisms that drive the decisions. So we're going to think about things like stigma. We're going to think about things like information. Then we're going to investigate moral hazard concerns with respect to smoking. So one of the concerns with screening is that imagine that you receive a screen that says there's no evidence of lung cancer and that you love smoking. Well, this might be an excuse for you to continue your smoking. Conversely, you could imagine that same scenario where you get a clean scan and you might say to yourself, well, this is my opportunity to quit. There might be like a value of life effect. So we can explore that in a model. And we're going to simulate the model under a variety of counterfactual scenarios that broaden or change eligibility. And we can think about then selection into screening, that remove stigma, that improve the quality of the screen, so we reduce the false positive rate, and potentially correct incorrect beliefs. As you might guess, in the US context, there is no panel data set that follows the same people over time, measuring their screening and smoking decisions and their health outcomes. To the extent that those data exist in a European context, I would love to talk to any of you because we simply don't have it. So in the US, what we'll do here is cobble together a number of data sets to try to estimate some of the parameters of this model. And I'm going to focus on the first two. So we've done a novel survey that I hope will be exciting to everyone in the room, and some really exciting kind of EHR data on a pretty macro level. So I'm going to focus on those two today. Preliminary results. So in our survey, what we did was a randomized information experiment. And again, we're trying to kind of gauge people's intentions to screen or not, to choose lung cancer screening. And so I'll talk about the population that we kind of dealt with here when I get to it. But the headline results are that when we targeted stigma, so the extent to which people are kind of uneasy or uncomfortable with the notion of, or the reputation associated with screening, that increased screening by 10%. When we targeted screening quality information, so when we told people the true false positive rate, that actually decreased screening by 1.9%. When we informed people of their eligibility for free screening, that increased screening by 35%. And when we randomized prices out of pocket that a person would have to pay, we see a pretty natural downward sloping demand curve. We also find no evidence of this moral hazard effect. Okay, so when we gave people a hypothetical scenario of a clean scan, we actually found an increase in the likelihood of quitting. So we can rule out any kind of moral hazard effects pretty confidently with our data. And we can contribute a new estimate of the false positive rate of lung cancer screening of 12% in the Truveta EHR data. So those are the results that we have so far. And again, the next steps will be to kind of estimate the structural model. Briefly, I'll just talk about the literature that we're contributing to. There's a growing literature in economics on screening, particularly this INEV paper in 2020 in the AER. They're thinking about mammography, but they're thinking very, very closely about this idea of like, what if we expand the eligibility criteria for screening? Who are the people who are choosing to select or choosing to screen around those margins? And we're also thinking about growing literature on information and health behaviors. This is where Alex and I have individually done more of our work, thinking about how is it that health behaviors change when people learn that something's not right with their health. So I'll pause there. Hans, if you have any, I don't know if anyone has any questions.
So far, no questions, Michael.
Okay, all right. So I'm gonna jump into the theory just for Davide, and then we'll we'll get to the data. So keep in the back of your mind that the goal of this model is something that we want to take to data. So we want to do a structural estimation of this model. So that's where we're coming from. But we're thinking about a dynamic model of smoking and screening behavior where those two things are chosen jointly. The model needs to feature a number of things that are important in this market, including addiction, health dynamics, mortality, learning, and competing risk. I haven't really talked about that, but one of the reasons you might choose not to screen is because you have another chronic condition that is, limiting your life expectancy in some significant way. So take a representative period. Everything in the lung cancer screening literature is on the yearly and annual basis, so you can think of this as a year as well. But there's going to be a state at the beginning of the period. A person is going to receive a draw of symptoms. So one of the main reasons that people choose to screen is because they develop a cough. And so we want to incorporate that in our model. Then they're going to choose whether or not to screen and whether or not to smoke simultaneously. If they chose to screen, they would observe a signal of information from the screening. And I want to emphasize that the screening is not perfect, right? The screening in the model here, you receive a signal of information, but there could be a false positive, right? False negatives are pretty rare, but false positives are not rare. And so even though you're observing this, screening result, it's not definitively telling you your cancer state. Utility is realized, and then these states update, and a person may die at the end of the period. Okay, so let me just go through these boxes. The states that we're thinking about here are a lung cancer state where we're, again, simplifying to try to make it tractable of none, early stage or late stage. And importantly, theta here is not known to the econometrician or to the person. Okay, if that were known to the person, there would be no need for screening. There's a diagnosis state, which is whether or not the person knows theta. B is the subjective probability of any lung cancer. Okay, so a person has beliefs about the state, and that's what's informing their decision making. H is smoking history, because we think that that's important both for the health dynamics, but also for the price of screening. Another health state where that is just going to be a 0, 1, 2, 0, 1, whether or not there's a chronic condition, and an individual type new, which says, some people have a lot of stigma about screening. Some people want to avoid information, would actually pay to avoid learning these things. Some people have, incorrect beliefs about quality. And so we want to capture that. After the state, the symptoms that are revealed as a draw from a distribution that is centered around the unobserved state. So you could imagine somebody who doesn't have lung cancer at all developing a cough for a couple of weeks. That's a symptom draw. That's not necessarily evidence of lung cancer, but it might get someone a little afraid. And so you can imagine that the distributions of early stage no cancer and late stage cancer, the distributions of symptoms might overlap to some extent. So we would allow for that. Following the revelation of this symptom draw, beliefs update in a Bayesian fashion. And then a person chooses whether or not to smoke and whether or not to screen based on their state. Okay, so it's a fairly standard, like, dynamic stochastic model. Then if the person chose to screen, they would observe Z, which is a result of their screening. And we're going to allow for false positives and false negatives. Okay, so again, like I said, the fact that you observed a screening result doesn't tell you your cancer state perfectly. And so this row here is saying, okay, conditional on lung cancer, what is the likelihood of a positive result, for example? And so, we're going to, you could imagine that a person would learn about these probabilities as well. I'll show you survey evidence that actually in our sample later that people actually get this pretty close to the right answer. So to the extent that they're wildly biased, I don't think that's the case. Utility is going to be a function here of the choices and the state where there's a lung cancer specific intercept. And then you've got kind of a standard relative risk aversion formation here, where income W minus the price of smoking and screening minus the potential for payment for treatment for lung cancer. But I'm going to not talk about that. And then we have a standard kind of reinforcement effect here for smoking. So the utility from choosing to smoke is going to be a function of your history of smoking. And then some terms here based on type. So this term here, where we sum over the new terms, is allowing the screening decision to cause disutility for different types. So some people might not have any kind of stigma or avoidance of information. Others might have significant amounts of that. Prices enter linearly, and the presence of symptoms would also be a negative utility draw. Then beliefs and states update. The other health state is in there as well. The cancer state, the smoking stock, all of these things update. And at the end of a period, a person may die as a function of all of that stuff. So let me just talk about the summary of the model. Um, in our model, the benefit of screening is to diagnose cancer before it progresses. So, there's an understanding we're assuming here of the individual in the model that being diagnosed with late stage cancer is almost a death sentence, whereas being diagnosed with early stage cancer yields some possibility of survival. And in that sense, screening is valuable. It also resolves uncertainty. And so in a kind of Krebs and Porteous kind of way, we might think that a person values uncertainty coming down. The cost of screening in the model, there's a monetary cost, potentially a stigma cost, and potentially an information revelation cost. It's not fun to get bad news. I don't want the screening staff to treat me disrespectfully, or I might have some stigma associated with my family or some stigma, and there's a monetary cost. For smoking, it's all about preferences. A person might have a high addictive stock, and they might really just the marginal utility of smoking might be enormous. And the cost of smoking, it costs money, and there's potentially health implications. So
Michael,
let
I
me
do
talk
have a
about,
question myself,
yeah,
actually.
yeah,
So on the, I can sort of totally see why you want to allow for sort of simultaneous decisions of screening and smoking.
yeah.
But I'm just wondering, like when you mentioned before, I think that when you take it to the data, it's going to be at the yearly level. And so I was just wondering, like, then the timing within a year, let's say, of the screening is still going to make some difference, I guess, right? Like, it's not fully simultaneous. If, let's say, the screening takes place in January, and you then probably smoking decisions later in the year will be based also on the outcome of the screening, no? So how I'm just wondering about the timing within a year, I guess.
Yeah, no, that's a really good point. I mean, ultimately, we are not going to be estimating a model at the yearly level. And that's just because we don't have data for that. So we are going to I'll kind of talk about what we're going to do at the end. This is kind of a GMM procedure where we're going to say, okay, we have this randomized survey information experiment stuff, and we're going to match some of the utility parameters to those moments that come out of our information experiment. But more generally, I mean, I agree with you, right? So like if you had annual data, this would be a problem because you'd observe screening, even if you observe the date, right? You would observe smoking kind of it, the questions are, as you know, the questions are typically, tell us about your smoking behavior over the last year. They don't ask when did you stop or when, um, I think because you would not observe that, you would have to just proceed by assuming that they were simultaneous, and you'd have to kind of caveat your results in a sense. But yeah, I mean, it's always nice to get more granular on the time dimension. Uh, okay, so really quickly about Truveta. So Truveta is going to be I think probably the closest that you might find in the United States to a kind of a European administrative data set. This is an EHR data set that covers 130 million electronic health records. Um, it has coverage over 100 different health systems in the US, which is really exciting because a lot of the times in the US, the problem is that, I might get care at Johns Hopkins Hospital, but then, I actually live closer to Washington, so I might go for a checkup at MedStar or Georgetown or something like that. And in the US context, we would not observe that sequence of events because they're in different systems. The Truveta data solve that problem because it has almost all of the systems. So you can actually observe someone going from system to system, and it's very comprehensive. So just millions and millions of records. Okay, so what we did here was we focused on data after 2022 when we had the most recent public health task force change in screening eligibility. And we looked at all lung cancer screenings that existed in the Truveta system. So we had 212,000 initial screens. 13% of them are observed later to go for some confirmatory testing that followed the lung cancer screening. And then we're going to focus our definitions on this diagnosis that exists in the kind of third wave here. So was the person diagnosed with lung cancer following within 12 months of the initial screen? And we're going to define our false positive rate here as something other than a no cancer result, conditional on no diagnosis of cancer within a year. And so we also have information here on cancer treatment, whether or not that's observed. And so you will see some people, for example, who never were diagnosed with lung cancer in the year, but received cancer treatment. And so we think that that's mostly like other forms of cancer that appeared during that time. So we're going to focus on diagnosis, but I will tell you if we included treatment as well, this estimate would actually be very similar. It'd be like 10.6%. So the way to think about the false positive rate for us then is going to be whether or not you, for of the people who were not diagnosed, so 25,000 plus 181,000, how many of them received something other than no cancer from their test? 25,000 for a false positive rate of about 12%. And that's fairly consistent with the literature. It's a little bit lower, but this is also a fresher sample, more recent sample. And again, if we brought in the cancer treatment information, we would get about 10.6%. So roughly in that ballpark. It's the way to think about false positives. Our survey data. Okay, so I was talking to Davide earlier. This is like something that economists never did in the past, really, right? And it was, we do focus, I think, correctly on revealed preference. But increasingly, it's like I think very helpful to just ask people what they're thinking when they approach a market. I've been convinced of that, but by Stephanie Stancheva's work and other people who have been doing a lot of survey research. So in this context, because we think that attitudes about cancer detection and we think that beliefs about screening effectiveness really matter, at least they matter according to the medical literature. We wanted to do a survey where we just ask people how they're feeling about these issues. And so for those of you who are in the survey world, Prolific is a nice resource. It's not perfect, and I'll talk about some of the caveats here with Prolific, but it's good for two reasons. One, it allows you to get a sample of individuals who are from a select population. So we're going to focus on people who have some smoking history and are above the age of 40. Okay, we chose 40 because the recommendation is to start screening at 50, but they've broadened that, so we want to think about people who are a little bit younger as well. The other reason that it's really nice is that it's relatively cheap. So you can get data on people. You pay them an hourly rate, and they come to the platform and do surveys for extra money. So we have some information that our population is actually pretty similar to large national kind of administrative data sets. So pretty confident that this is not completely a selected group. And we're going to get information on 4,000 people on their beliefs and preferences and their constraints with respect to lung cancer screening. We're also going to do two randomized information experiments. So the other nice thing about Prolific is that they actually already have a bunch of demographic and socioeconomic information on the people, so you don't have to ask that stuff in your survey. You can simply just focus on the kind of heart of what you're interested in. So and let me just say that some of the questions that we're asking are really designed to eventually match to moments that the structural model would produce. So we're going to ask about risk preferences because that was an important feature of the utility function. We're going to ask about time preferences because clearly, this is an intertemporal trade-off. I'm going to incur some costs today to help myself potentially in the future. We're going to ask about health insurance status, income, their residential zip code, so where they live, and current smoking behavior and smoking history. That's baseline information. We're also going to collect information on risk perceptions. So here's the question that we ask people. Imagine a group of 100 adults just like you, same age, same smoking history, same overall health. Even if they haven't been diagnosed, some may already have early stage lung cancer without knowing it. In your best estimate, how many of these 100 people do you think currently have early stage lung cancer? So this question is almost exactly straight from Kip Viscusi's work on this set of risk perceptions in smoking. What we did is we anchored our slider at 51, which is pretty high, obviously, for this question. And we treat 51 as a missing if somebody didn't move it. I'm going to show you statistics on all of these questions after I present them. So then we asked a question on sensitivity. So imagine a person who has early stage lung cancer, meaning that the cancer is present, but they haven't shown any symptoms yet. And suppose the person receives a lung cancer screening test. In your opinion, what's the chance that the test detects the cancer? So that's a true positive. And then we asked the kind of similar question about false positives. Now imagine a person who does not have lung cancer, and they're healthy and have no symptoms. And suppose they receive a test. What is the chance that the test wrongly says that they do have cancer? So we're trying to get a sense, understanding that these kind of questions are not easy for people who aren't versed in probabilities, right? So we do a lot of kind of sensitivity to these kind of questions, which I'm not going to present today, but taking these questions with a grain of salt is important. Then we ask questions about baseline stigma. So two questions. How do you think people close to you would react if they knew you went for a lung cancer screening? And the answers there are very supportive to very judgmental. And then, do you think getting screened for lung cancer sends a message about your past behavior? Strongly agree to strongly disagree. So we create a couple measures of stigma, but the simplest one is just, did somebody say very judgmental or strongly agree or agree on either of these questions? Okay, and then after we've collected all this baseline data, we do a randomized information assessment where we're trying to simply just gauge the effect of different interventions on intention to screen. So this is a flow chart of the experiment. We have our sample of US adults age 40 plus with 1 year of smoking history at least. Because of all the baseline information we have, we can actually assess whether or not they're eligible for screening, eligible for free screening. And so we determine whether or not they're eligible, and we break people into the two groups. For the eligible group, we randomize them to one of 4 arms: an eligibility group, a stigma group, a control group, and a quality information group. And then we ask them intention to screen questions, 2 of them, one on a continuous scale and one on just a binary question. We do some comprehension stuff at the end that I can show you when I get to the results. For the ineligible group, for the people who don't meet the task force criteria for free screening, we randomize them again to 4 arms where the quality information, the control, and the stigma information are all the same, but now they could be randomized to an out-of-pocket price of $100, $300, or $500. Again, in the US, there's a lot of variation, but on average, it's about $300 in reality. And the same continuous and binary questions and the same comprehension questions. So here's the way the question is asked. So the control framing of the question is on a scale from 0 to 100, where 0 equals definitely not and 100 is definitely will, how likely are you to seek a lung cancer screening in the next 12 months? If you were randomized into the stigma targeting arm, then we added on top of that control framing the following language. So lung cancer screening is a clinical test like any other. Whether you smoke now or used to, staff are trained to treat every patient with dignity, and screening results are kept private. The quality target said, out of 100 people who get today's standard lung cancer screening, about 12 will have a false alarm, a positive result when no cancer is present. Most of them are cleared with a repeat scan. So that's targeting beliefs about the quality of the test. And again, like, a priori, we don't know which way that's going to go because it depends on their baseline beliefs. And so that's why we measured those. And then for the price target arms, of the eligible people for free screening, we say, because of your age and smoking history, the U.S. Preventive Services Task Force recommends annual lung cancer screening. For most people in your situation, insurance covers the test at no cost to you. For the ineligible group, we said, because of your age and smoking history, you are not recommended for lung cancer screening. If you choose to receive a screening, most people in your situation pay an out-of-pocket price of about X. So X is 100, 300, or 500, and that was randomized. All right, so after that, we do some comprehension questions, and then we do a smoking assessment where we have a simple treatment and control design where we say, okay, thinking about the next 12 months, please indicate which option best reflects your expectations regarding your smoking behavior, where the options were, I could smoke more, I'll smoke the same, I'm going to quit, I don't smoke now and won't continue. Versus a treatment group where we say, suppose a recent lung cancer screening revealed no evidence of cancer. And then we ask the same question. Okay, so our sample was constructed from the 4,000 people that we had. We essentially get down to a clean sample of about 3,900. One of the nice things about running this in Qualtrics is that you have this reCAPTCHA score, which is designed to kind of identify bot-like behavior. The standard in the literature is that anything over 0.5 is likely a human. It ranges from 0 to 1. Anything less than 0.5 is likely a bot. So we drop a small number of people there. And we have some missing values, but not too many. Okay, so covariant balance. So let me just tell you what this is. So we have a variety of characteristics, their means, and then we present 3 p-values. The first p-value is equivalence across, like a test of equivalence across all 4 arms. The second p-value of the screening experiment. The second p-value is conditional on being randomized to the out-of-pocket price of 100, 300, or 500, that there were no systematic differences across the 3 prices. And then the third p-value was the smoking experiment at the end, control versus treatment. And so we do, I think, quite well on these, on the balance. There's no evidence really. More than you would expect. One of these is significant out of about 50 that we run. So that's what you would expect.
Michael, Davide
yeah.
still has a question on the design. Davide, do you want to?
Sure, yeah, yep.
Oh, yeah. So it's actually 2 questions. One is whether you know do people know their eligibility for free screening? So how much do they know about the free screening environment, let's say? And the second one, but it's just because probably I just missed it. I was thinking about anticipatory feelings and information aversion, which you mentioned, but I
Yes.
didn't get how you measure that. You describe stigma, and I
Yeah.
don't know whether you are measuring it in the same way or in different ways.
Yes. So to answer your first question, I mean, I think we are informing a lot of people that they're eligible. I think that's what that screening is. That information treatment is supposed to do is say, oh, by the way, you are eligible. And most people I think don't know that.
Yeah, exactly. That was my point. So you are somehow updating a lot with respect to what they knew before entering the experiment,
Well,
which is fine.
we did, we did not measure baseline expectations about prices, right? So we don't know. Um, I would imagine, I mean, I'll show you in our results that was the biggest effect for that group. Um, then on your other question, yes. So we ask a question. Yeah, I'm paraphrasing now, but it was, sometimes screening may bring bad news. Would you prefer to delay or simply avoid that? And then the people could respond. So we'll use that in some heterogeneity,
Thank you.
but I actually don't have it in the slides. Uh, okay. Baseline covariates look pretty good. We measure risk aversion in this way that Shapiro and Kimball have recommended, where you can essentially ask these questions about labor market trade-offs, and you can construct groups of like the most risk averse person versus the least that map to CRRA parameters. And so we're going to control for these in our regressions, but importantly, they're not systematically different across our treatment and control arms. Same thing for time preferences. And then for same type of table here, 8% of our sample are uninsured, which is almost exactly the national average. You might be concerned that this is a group of people who really need the money for surveys, and that's not representative in some ways. But 25% of our sample have a household income of over $100,000 annually. So it's not just a student sample. It's not just a young person sample. 34% of our sample smoke cigarettes currently, but again, to be in the sample, everybody must have smoked some, so everybody else would be a former smoker. The number of pack years is 27. And then eligibility for free screening, 24% are eligible for free screening. 52% are eligible. They're over 50. 53% are eligible because of, would meet the pack years criteria, and 71% would meet the smoking criteria. You have to be all three of these, so that's why that 24% is lower. And 27% of our sample have received a screen in the past. Okay, and then here are our beliefs and expectations stuff. So when we asked people, like out of 100 people who look just like you, how many of them have early stage lung cancer? The mean is 22. And this is almost exactly what Kip Viscusi finds, that people dramatically overestimate these probabilities, right? So people, so the true value of this would be like 0.02, or point two, or excuse me, 2, whereas 2 out of 100. People are saying 22. And we asked them after that, and how do you think you differ from the average, right? And so about half of people said about the same. Some people said lower. Some people said higher. Belief of a false positive. Remember in the Truveta data, that was 12 out of 100 in the kind of like as big of a EHR database as you can find in the US. On average, we found 17 out of 100. So our interpretation of that was that people like have pretty decent beliefs about the quality of screening. That's not that far off. But it was skewed. So a lot of people said zero. So false positive information represents good news. So if you think that the false positive rate is 17%, if I come along and tell you it's 12%, then I'm bringing you kind of good news about the quality of screening. And so roughly half the people said had that. And then high stigma. So again, this is the simple binary, but 45% of people said that they would either kind of feel judgmental, like people would be judgmental around them about a screening, or um, they would that screening would like send some information, send some signal about your smoking that would be unsavory. Just to give you a little sense of the data, so the risk by state. So this is the self-assessed early stage cancer probability as a function of how many pack years they've smoked. And so people who smoked more generally think that people who look like them probably have higher risks of cancer. So that's I think that's interesting. What's also interesting is that there's really no relationship between the probability of early stage lung cancer as elicited from the people in the survey and their age. So basically a flat line there. Okay, so then the estimation equation, what we're going to estimate is Y is going to be some intention for lung cancer screening as a function of the subsidy, quality, and price arms, where the price arm is going to be broken by whether or not they're ineligible and whether or not they're eligible. And price can be 1, 3, or 500. We're going to include X's in all of our regressions. Again, you saw that our balance tables looked pretty good, but we're gonna include them. And then here are our main results from the survey. So the control mean for intention to screen in the next year was 38%. 30 point, it should be, yeah, so 38 out of 100. And so 38%. So the stigma information arm increased the propensity to screen by 3.8, so about 10% relative to the control mean. The quality information arm actually reduced it by a little bit, but not statistically significant. Informing people of their eligibility, conditional on their eligibility, increased by a lot. And then you see this kind of natural downward sloping demand curve with respect to those who are ineligible and the price that they were quoted for their screening. And then we did some heterogeneity based on the baseline characteristics that we have in our data. So if you were classified as high stigma, the stigma arm had a little bit bigger effect. So if you're somebody who said, yeah, I think the staff would be judgmental, or I think it would send a signal about my smoking history, telling you that the staff would treat you with dignity, not statistically different, but it was a larger point estimate. If you were somebody who thought that the false positive rate was more than 12%, then telling you that the false positive rate is only 12% actually increased screening a little bit, versus those who thought this was bad news. So if you thought that the false positive rate was 0% and I told you it was 12%, that actually lowered your propensity to screen. So that makes sense. And then we don't see big differences by income. So the effect of the subsidy was roughly the same for lower and higher income individuals, as was the price effects down here. Those were all roughly the same. And then we did some comprehension stuff. So one of the concerns with this type of research is that people are not really thinking about the questions, and they're not really investing a lot of time. And so what we did after the screening questions was to ask them three kind of comprehension questions. So we asked them, do you agree that screening is affordable? Do you agree that false positives are common? Do you agree that the staff would be non-judgmental? And so what you can see in the stigma arm, the stigma information arm here, is that the stigma info had a positive and significant effect on whether or not you think that there'd be judgmental staff. So, I mean, so in a good way. So I agree that staff would be non-judgmental, whereas the other two were insignificant. So we take that as evidence that people, to some extent, like heard the question. The quality information arm had no effect on relative to control, right? So relative to control, the quality information arm had no effect on whether or not people thought that it would be affordable. And it had no effect on people's assessment of non-judgmental staff, but it had a big effect on whether or not people thought false positives were common. So this is probably driven by the people who, again, at baseline, thought that the false positive rate was less than 12%.
Michael, just to mention that there's about 3 minutes left only.
Oh, great. Yeah, I only have a few slides left. Great.
All right.
Yeah, and then similar kind of action here. Do you think that the screening would be affordable? Yeah, I mean, yes, the being informed of the eligibility had a big effect, and so did a quote of 100. But then having a quote of 500 actually made people say less than. So we interpret this again as just kind of people were understanding the question. Final set of results. We show some evidence that when we present information of a hypothetical scenario in which a person was cleared of any kind of lung cancer from a screen, that actually encouraged them to smoke less in the future. The intention to smoke was lower, and the intention to quit was higher when we presented them that treatment. I just would view these results as saying that this kind of concern about moral hazard is not something that we're seeing in our data. The next steps for the project are to estimate the structural model with the data that we have and to simulate it under counterfactuals that would inform policy. So, changing the eligibility criteria for the USPS task force, improving screening quality, reducing stigma, things like that. So that's all I've got. I've got 2 minutes left, I think. So happy for any questions or follow-up discussion.
Yeah, thanks a lot, Michael. Well, Vicky had a question. Vicky, you want to raise the question yourself?
Yeah, thanks. I just wonder whether there are too many psychological aspects that are not rational, such as not wanting to think about cancer as a reason not to even consider getting screened. And is this really an economic rationality decision, or is it really a psychological phenomenon?
Yeah, I mean, so, how could we model that? I mean, so I agree with you, right? So there's like we're very sympathetic to this psychological issue here. We want to include it in our model in a kind of a horse race kind of way. So from a policy perspective, maybe the first order thing to do is just lower prices. That might be an answer, but it also might be what you say. It might be the case that people just like psychologically want to avoid information. So we measure that in our, and we can include that in our utility function and then kind of say, okay, which one of these is more important for the people in our center? So I think our goal here is to move beyond kind of a standard framework here and say, okay, we think stigma and like information avoidance and fatalism and these kind of things really do matter potentially, and we want to evaluate.
All right. Yeah, we are at the half hour. So what I suggest is that if anyone else has suggestions or comments for Michael, then feel free to write them an email. So thanks again, Michael, for doing this. And let me hand back to Davide to end the seminar and announce the next speaker.
All right. So thank you, Michael. Also on my side, it's fantastic paper, very interesting, and really taking into account the previous literature and going a step forward. Fantastic. So thank you again. And so for those who are interested in the Verb seminar series, we are going to have next seminars in 1 month. Actually, it's going to be the 13th of April, and the presenter is going to be Marcela Alsan. So be ready to receive the emails and spread the word. So thank you very much, everyone.
Yeah, thanks a lot.
Thanks, Michael.
Thank you. Thank you very much.
Take care.
All right. Hello, Tina. Bye.
Hey, yeah, take care.
Ciao. Ciao,
Bye.
ciao.
I may